Good morning, all of you. This is the first tutorial for the Manchester program in surgery, and this is how to do an abdominal examination, including the abdominal mass and other abdominal complaint, let's say the abdominal pain. Really, the interrogation of an abdominal mass starts with the patient complaint, that is, a patient coming presenting with an abdominal mass. The present history includes how the condition started. That's the time of the start of the patient presentation, the course, whether it's progressive, regressive, or stationary course, and any other associated symptoms that may include pain. Abdominal pain is a common complaint in a large category of patients, and this abdominal pain, most important of which is the colicky pain. Then the question is, how can we define colicky pain? This is a griping type of pain that ascends up and then descends down with free intervals in between. For the colicky pain to occur, there should be a hollow viscus that's contracting against some sort of obstruction. Most common is the intestinal colic, second is the urinary colic, and the third is the functional dysmenorrhea, where there is a functional obstruction in the cervix uteri. Then we have to discuss past history of the patient as illustrated in front of you. That includes there may be past history of bilharziasis and antibilharzal therapy that may indicate either bilharzal spleen or bilharzial pericolic mass. History of traveling abroad. Persons with previous travel to Iraq and Libya may have hydatid cyst. TB or admission to sanatorium. Surgical operations. Chronic liver disease or viral hepatitis. Diabetes. It may be associated with carcinoma of the pancreas, where is maybe a cause or maybe a result of carcinoma of the pancreas. Hypertension. History of typhoid fever that may denote the arthritis or aortic aneurysm, and lastly, syphilis. You have to interrogate the family history of the patient, whether there is or there is no similar conditions in the family, including hemolytic anemia that presents abdominally with splenomegaly or gallstones, cystic disease involving the liver, pancreas, liver, and the kidney, intestinal polyposis, and family cancer syndrome. Gynecological and menstrual history, where you cite the age at menarche, age at menopause, menorrhagia, metrorrhagia, vaginal discharge, the gravity, parity, and the history of intake of contraception pills. Then you move to the general examination, where the patient is lying supine. Before that, he is coming quiet, oriented, cooperating with the examiner, with normal decubitus and the gait. The basic parameters: pulse, temperature, and the blood pressure, pallor, cyanosis, jaundice, pulsating congested neck veins, Palpate organs in the general exam, palpate the thyroid, palpate the cervical lymph nodes. Then you do a complete chest exam, heart exam, examine the upper limb for clubbing of fingers, tremors, pulmonary edema, splinter hemorrhage, Dupuytren contraction, other signs and manifestations of liver cirrhosis. In your present history, let's go back to the present history once again. You have to interrogate about different body systems, upper gastrointestinal symptoms, lower gastrointestinal symptoms, urinary symptoms. Is there or there is no history of trauma? Is there or there are no signs of inflammation? That includes the general evidence of inflammation and local evidence. Let's remember the general manifestations of inflammation: fever, headache, sweating, malaise. And the local manifestations: hotness, redness, tenderness, swelling, and edema of the skin. This abdominal mass may be malignant, so you have to ask about evidence of metastasis, whether in the liver, lung, brain, or bone. In order to be oriented with the abdominal examination, let's divide the abdomen while the patient is supine into 9 regions by 2 horizontal planes and 2 vertical planes. 2 horizontal planes: the first is midway between the xiph-sternum and umbilicus, the lower horizontal transtubercular that lies at the level of tubercles of the iliac crest, that lies 2 inches behind the anterior superior iliac spine, and 2 vertical lines that are the midclavicular or nipple lines. The lines are shown in the figure above as arranged from 1 to 9. These are the right hypochondrium, epigastrium, left hypochondrium, right lumbar region, umbilical, left lumbar, right iliac fossa, hypogastrium, and the left iliac fossa. If the case shows that there is a mass in the right hypochondrium, you should put in mind what are the anatomical organs that are situated in the right hypochondrium. So you may have the liver, the gallbladder, the right kidney, the right colic flexure, and maybe other structures entering the colon. Number 1, the liver presenting as a mass in the right hypochondrium may range from liver abscess, whether it may be a biemic big abscess or an amoebic liver abscess, primary tumor, that's hepatocellular carcinoma, metastatic tumor that are characterized by being multiple with central umbilication. This central umbilication may be caused by central necrosis because, as you see, the central part of the metastatic lesion is the least part to receive blood supply. It may be a mass presenting a normal anatomical structure, that's Riedel's loop, that may be found in female more than in the male, and it is a tongue-like projection from the right lobe of the liver. A regenerative nodule of cirrhotic liver may present as a mass, hydatid cyst. Then we go down to a mass that may arise from the gallbladder. It may be a mucocele or an empyema or carcinoma of the gallbladder. Whether a mucocele or empyema results from obstruction at the neck of the gallbladder, leading to accumulation of mucinous secretions inside the gallbladder that may attain a very huge size, even going down to the right iliac fossa. And whenever this mucocele is having a bacterial infection, it leads to the development of empyema. Let's go down from the liver to the kidney and suprarenal gland. So you may have a suprarenal tumor when it's very large in size, and this is rare to occur. Kidney mass that may include renal cyst, renal tuberculosis, hydronephrosis, renal abscess, perinephric abscess, renal tumor, a polycystic or multicystic disease of the kidney. Go more down where you find a carcinoma of the hepatic flexure or the head of insusception, that's an ileocolic or an ileocecal insusception, going up till the level of the extreme upper part of the ascending colon or the hepatic flexure, the right hepatic flexure. It's okay. When we go to the other side of the abdomen, upper abdomen, that the left hypochondrium, you may find the following masses. It may arise from the stomach, from the spleen, from the body of pancreas, from the descending colon, or from the kidney. In the stomach, you may have gastric distension, and this gastric distension leads to gastric dilatation or results from gastric dilatation that may be detected by the simple clinical examination. You know, that's succussion splash. When you put your stethoscope on the back of the patient, then move him forward and backward, you listen to a special sound which is called the succussion splash. An advanced big carcinoma of the stomach, okay? And in the spleen, you may have congested spleen, portal hypertension, lymphoma, splenic abscess or infection in the spleen. Then the body and tail of pancreas, carcinoma of the body or tail, and pseudo-pancreatic cyst. In the descending colon, you may have a carcinoma or impacted feces. It's to be noted that most of the masses that are felt in the left side of the colon, this is mainly the damned stool, which is felt above the level of the obstructing carcinoma. Similarly, a lesion in the left kidney like that on the right, if you remember, ranging from TB, renal cyst, hydronephrosis, renal abscess, tumor, or polycystic or multicystic disease of the kidney. We go to the epigastric swelling. That's a mass in the epigastrium. It also ranges from the stomach, transverse colon, omentum, and so on. In the epigastric swelling arising from the stomach, this may include carcinoma, advanced carcinoma of the stomach, pseudopancreatic cyst, tumor of the head of pancreas, pyloric stenosis with gastric distension. In the transverse colon, it may be carcinoma of the transverse colon, impacted feces, and omental mass secondaries in the omentum and omental tumors like mesothelioma. Lymphadenopathy, the para-aortic lymph node, whenever they are usually enlarged, dermoid cyst, and never forget the aortic aneurysm. So as a base of information, the aortic aneurysm is felt above the level of the umbilicus, about half an inch above and to the left side of the umbilicus, due to the fact that the aorta bifurcates at the level of half an inch above the level of the umbilicus and to the left side. Umbilical region swelling that may include structures coming from the stomach, carcinoma, leiomyoma, and leiomyosarcoma, transverse colon, impacted feces and tumor, a mass from the omentum, whether inflammatory or neoplastic, aortic aneurysm, retroperitoneal structures like retroperitoneal sarcoma, lymphadenopathy, small intestine, Crohn's disease, mesenteric cyst, tumors of the small intestine, but this is rare care. Most important is the right iliac fossa mass. In the right iliac fossa mass may arise from the cecum, like carcinoma of the cecum presenting as a mass, because as you know, the right side of the colon, the cancer presents as a right iliac fossa mass, a cauliflower mass, while that of the left side is a stenotic mass. A mass arising from the terminal ileum, like Crohn's disease or TB enteritis, from the appendix, appendicular mass, and appendicular abscess. Let's say if the kidney is an ectopic kidney, as you know, the kidney is developed down in the pelvis and then ascends up to its normal anatomical position. So if we have a renal tumor developed in a failure of this of ascent of the kidney, it will present downward in the pelvis. And on the other side, the testis is developing up in the second lumbar region, in the opposite to the second lumbar spine. If there is a rest of descent at the level of the right iliac fossa, it leads to the development of a tumor developed in an undescended testis. In a female, whenever you are having a mass in the right iliac fossa, you should put in mind other gynecological causes like ovarian cyst or ovarian tumor, ectopic gestation, biosalpinx, and these are arising from the female reproductive organs. Go to the other side, that is the left iliac fossa. It may arise from the sigmoid. In the old days, we were accustomed to have bilharzial pericolic mass. That's a granuloma occurring towards the serosa of the left side of the colon, a peridiverticular abscess, carcinoma, dammed stools above the level of obstructing carcinoma, a pelvic kidney, a tumor in an undescended testis, ovarian cyst, biosalpinx, and ectopic pregnancy. Go down and central to the hypogastric swelling, where we have retention of urine. This is a clinical problem the clinician should be alerted to, where you find a hypogastric mass. It's tender, and whenever you press, the patient feels a desire to micturate. This is retention of urine. It's pelvic abdominal cystic and gives the criteria we have mentioned before. Pregnancy, which is a normal physiological condition. Fibroid of the uterus. Endometrial carcinoma. Ectopic gestation. Biosalpinx. Ovarian cyst. Ovarian tumor.